Case report of a male patient with hypoglycemia unawareness due to late diagnosis of type 2 diabetes mellitus. Introduction. Obesity. Obesity is the most important factor of insulin resistance and therefore the main cause of diabetes. Hypoglycemia. Hypoglycemia is defined by the American Diabetes Association as a decrease of the blood glucose levels below 70 milligrams out of deciliters. This is an avoidable consequence of inadequate diabetes treatment. Hypoglycemia unawareness is the onset of neuroleukopenia due to the neuronal response produced by hypoglycemia and the inability to detect a significant drop in glucose. Methodology. Databases such as U.S. National Library of Medicine, PubMed, World Journal of Diabetes, and Clinical Key were consulted. The main keywords were type 2 diabetes criteria, hypoglycemia, hypoglycemia unawareness, hypoglycemia, hypoglycemia management, hypoglycemia criteria, moderate hypoglycemia, and obesity criteria. The search for articles was filtered by journals from 2015 to 2021. Articles that did not include those keywords and no English or Spanish articles were excluded. Patient description. 47-year-old male, former smoker, without allergies, without surgical interventions, and his last medical consultation was 7 years ago. He has no other relevant antecedent. He goes to the consultation referring that he has headache, diaphoresis, palpitation, blurry vision, dyspnea, and nausea. The patient is conscious, but his speech is difficult to understand and has some signs of confusion. Case history. The patient began with the first symptom being the headache 4 hours before he entered to the emergency area. Approximately 45 minutes later, the nausea appeared, followed by episodes of palpitation, blurry vision, and diaphoresis. He mentions that in the 2 previous days, his daily food intake had decreased considerably due to a diet based on low carbohydrates and proteins. He was questioned for previously diagnosed comorbidities which were denied. His wife mentioned that the patient has had nocturia for 3 months. In his hereditary antecedents, only his mother was mentioned as having been diagnosed by hypertension 10 years before her death. He consumes a lot of carbohydrates, sodas, and few vegetables. He doesn't exercise, and afterward he has a sedentary lifestyle. The patient consumes alcohol since he has 18 years old, and he is a former smoker, but he started to smoke from the age of 16. Physical examinations results. The patient has a blood pressure of 130 out of 70 milligrams of mercury. Heart rate was 107 beats per minute. His respiratory rate was 18 per minute. He has a saturation of 97%. His capillary glucose was 50 milligrams out of deciliters. He has a weight of 205 pounds and a height of 5'6" feet. His BMI was 31. BMI of 31 represents obesity class 1 following the most recent data from the U.S. National Health and Nutrition Examination Survey in 2014. Indicate that obesity is defined when we have a BMI over 30, as the table 1. The patient was weak. The speech was difficult to understand, but he was cooperative. In the physical examination of the neck, only acanthosis nigricans was found. In chest examination, its appearance, color, symmetry, and temperature and the skin was normal. At the abdomen examination, the palpation, auscultation, and percussion did not show abnormalities. There were no scars, the abdomen was symmetrical with a normal temperature, and there was no reason for genital tract examination. Neurological examination was based on the Glasgow Coma Scale. The findings were summarized in normal with a good state of consciousness. Table 2. Examination results using the Glasgow scale and interpretation of patient's score that shows that he has a good consciousness. Examination. E-response. Results. 3 points. The patient responds to speech without the need to touch him or generate another stimulus. Examination. Verbal response. Results. 4 points. The patient answers some questions correctly and stays in the conversation, but some of his answers are not specific or some words are difficult to pronounce. Examination. Motor response. Results. 6 points. The patient responds to the speech and obeys orders. Total score. Results. 13 points. Patient with good consciousness. Results of pathological test. Laboratory tests in his admission include an oral glucose tolerance curve. The patient was fasting. A bolus of 75 milligrams of glucose was used. After the first 60 minutes, the plasma glucose was 50 milligrams out of deciliters. After 120 minutes, the glucose rose to 100 milligrams out of deciliters, but fell again after 214 minutes with 58 milligrams over deciliters, as the table 3. Therefore, the results of the glucose tolerance curve indicate that the patient has moderate hypoglycemia. Liver, thyroid function, and blood count was indicated as well, without abnormalities. 12 hours after the admission, hemoglobin glucosylate level test was applied with a result of 7%. The patient was diagnosed with diabetes mellitus. Treatment plan. The initial treatment plan consists on the management of moderate hypoglycemia using digestion of rapidly absorbed carbohydrate. Follow-up treatment consists of managing of the diagnosis of type 2 diabetes mellitus with 1. Lifestyle modification. The patient will be referred to a nutritionist for a change in his diet, and it will be suggested that he needs exercise at least 30 minutes per day. 2. Pharmacotherapy with 1 daily oral tablet of metformin, 850 milligrams every 8 hours. And 3. Blood glucose monitoring. Continuous monitoring of blood glucose every week using capillary glucose measuring equipment is recommended to the patient. Expected outcome of the treatment plan. 1. Reduce BMI. After 1 month of starting the change in his lifestyle, the patient will reduce his BMI to below 31. 2. Glucose level control. The control of glucose levels will be stabilized by the pharmacotherapy using oral metformin. And 3. Decrease of hypoglycemia. The incidence of hypoglycemia will decrease significantly because of the blood glucose monitoring. Actual outcome. The patient has dropped from 205 pounds to 182 pounds. His BMI decreased from 31 to 27.4. Despite following his treatment, during weeks 2 and 3 of the start of his treatment, the patient registered hypoglycemia at the end of his exercise routine. Capillary glucose levels were below 70 milligrams out of deciliters, but above 50 milligrams over deciliters. Findings. 47-year-old male with headache, diaphoresis, palpitation, blurry vision, dyspnea, nausea, and conscious with some signs of confusion. In the 2 previous days, his daily food intake had decreased considerably due to that he was subjected to a diet based on low carbohydrates and proteins. The patient was questioned for previously diagnosed comorbidities which were all denied. It was recorded on physical examination a capillary glucose of 50 milligrams out of deciliters and a weight of 205 pounds with a height of 5.6 feet, which gives a BMI of 31. In the physical examination of the neck, acanthosis nigricans was found. The results of the glucose tolerance curve indicate that the patient has moderate hypoglycemia. The hemoglobin glucosilate level test that was applied gave the result of 7%. The patient was diagnosed with diabetes mellitus. The episode of hypoglycemia have not diminished. The patient registered the episodes at the end of his exercise routine. All of them were with capillary glucose below 70 milligrams over deciliters, but above 50 milligrams over deciliters. Discussion. The onset of the neuroglycopenia before the first appearance of autonomic symptoms or the inability to detect a significant drop in blood glucose is due to hypoglycemia unawareness. An early diagnosis of diabetes mellitus significantly reduced the complication of this comorbidity, with the hypoglycemia unawareness due to recurrent hypoglycemia being one of those complications, which suggests that if the patient had been diagnosed previously from the month in which he presented the first symptom, bacteria, the control of his glucose through the treatment will allow a prevention of recurrent hypoglycemic episodes. The presence of low plasma glucose levels and neuroglycopenia that improve after carbohydrate administration make a Whipple's clinical trait, which readily establishes the diagnosis of hypoglycemia while improving the patient's condition. As demonstrated in the case, the patient presented signs of neuroglycopenia that gave suspicion of being a case of moderate hypoglycemia. The treatment that consisted of managing the intake of rapidly absorbed carbohydrates results in both the control of hypoglycemia and confirmation on the diagnosis. It means that the Whipple's clinical trait was positive. A sudden change in the diet of the patient consuming excess of carbohydrates as well as saturated fat in conjunction with excessive physical activity predicted the onset of hypoglycemia. However, change in lifestyle is essential for the treatment of diabetes mellitus. Once the patient gets used to it, it is hoped that there will be a better relationship between his blood glucose levels and the new lifestyle. Therefore, the previously established treatment follow-up does not need to be modified. There is evidence that shows that a healthy lifestyle and a balanced diet constitute the most important basis in treatment to improve control of glucose levels, lipid levels, blood pressure levels, and reduce cardiovascular mortality. Conclusion. A sedentary lifestyle together with poor nutrition leads to obesity, which is the main factor of diabetes mellitus. An early diagnosis of this disease provides an adequate intervention in the improvement of the lifestyle and pharmacological treatment for the patient in order to improve their quality of life and reduce the complication that may appear, for example, hypoglycemia. Hypoglycemia unawareness appears after several recurrent episodes of hypoglycemia with low levels. Patients with hypoglycemia unawareness are not able to realize that they are having an episode of hypoglycemia until the symptoms of neuroglycopenia, such as sweating, headache, blurred vision, tremor, and a state of confusion appear. The basic management of this type of patient who frequently attend the emergency area is based on the correct diagnosis of hypoglycemia with capillary glucose levels, an oral glucose tolerance curve, and the intake of rapidly absorbed carbohydrates to increase blood glucose, which confirms that the Whipple's trait is present, and also the adjustment in their insulin levels if it is required. In patients with type 2 diabetes, for the prevention of recurrent episodes of hypoglycemia, their lifestyle is modified through exercise and a balanced diet personalized for theirs. Health personnel are recommended to tell patients that continuous monitoring of blood glucose levels is important to complement their treatment and prevention of hypoglycemia unawareness.